Good afternoon, good evening, good morning, or wherever you are. Welcome to this first series of webinar organized by the Community Health Academy with Last Mile Health. Uh, I would like to start first of all by apologizing for being late. We were experiencing some technical difficulties, but with support from our host, Tech Change, we've been able to resolve some of those difficulties. For today's webinar, which is in support of our health systems leadership training programs that we are starting to launch pretty soon, as a matter of fact, on the 9th of May, we wanted to run a series of webinars to support learners and other interested parties who are logging on to our online training programs. For today's webinar, we have three speakers. First, we will hear from Nazo Qureshi of USAID, and then I will introduce Jim Campbell, who is the Director for Health Workforce Development with the World Health Organization. So I'm going to start first of all by introducing to you Nazo Qureshi. Nazo serves as the Senior Community Health Systems Advisor in the Office of Health Systems in the USAID Bureau of Global Health. Drawing on over 2 decades experience in health and development in multiple countries, she guides policy, program, and partnership priorities focusing on community health systems to advance USAID's goal in health in priority countries. Ms. Qureshi also serves as a member of the core team of the Community Health Roadmap to coordinate, align, and increase investments in primary care at the community level by elevating national priorities defined by governments. She leads USAID's direction in community health system strengthening through innovative partnerships between government and civil society in multiple countries, including the Integrating Community Health Portfolio, and initiated the current collaboration of community health with UNICEF and the Bill and Melinda Gates Foundation. Ms. Qureshi serves as a member of the expert panel of the Comprehensive Review of Evidence for Community Health, Primary Health Care. I'll now hand you over to her for her presentation. Thank you.
Hello, everyone. I am Nazo Qureshi. I am the Senior Community Health Systems Advisor in the Office of Health Systems in the Bureau for Global Health at USAID. It's a real pleasure and a privilege to be a part of the global faculty for the Community Health Academy and to participate in this webinar as we launch the first course. I will be speaking to you today about the importance of health systems leaders, your role at the country level in defining national priorities and plans and ensuring that community health worker programs are a critical and essential part of a country's national health system. It's a great time for our collective movement, focusing on institutionalizing community health, ensuring that community health is foundational to the national priorities and plans, to revitalize primary healthcare towards universal health coverage, and to achieve goals in health in the Sustainable Development Goals era. You are a part of the movement at the country level, systematically assessing and prioritizing critical health systems functions and enablers to optimize the potential role of community health workers towards greater equity and resilience and to accelerate national progress. We at the global level are working right alongside with you and taking your lead. Developing integrated community health worker programs is a part of this agenda and a critical component. It has a lot of visibility right now. Community health workers are links between communities and the formal health system. Developing integrated community health worker programs involves weighing pros and cons, making informed decisions, involving all stakeholders, and adjusting the course. And once again, your leadership role is essential to precipitating paradigm shift and working differently in the next decade. I'm going to focus today on two dimensions that are important and essential to working differently in our collective movement to institutionalize community health as an accelerator for primary healthcare. The first focuses on you, countries, leading a dialogue to define your priorities for institutionalizing community health and promoting an exchange of lessons and innovations with peers in different country contexts. And here you see in this slide, the Minister of Health from Niger with colleagues just after they had finished their prioritized plan for Niger, and I will discuss a little bit more about Niger's priorities when I finish this presentation. And the second focus is on us, how we, as a diverse group of community health funders, can support your priorities in community health, including sustaining and scaling high-quality community health worker programs. USAID is committed to supporting countries as they prioritize investment, shape policies, and strengthen systems for primary healthcare and community health. This builds on our long history of investing to improve equitable access to life-saving interventions at scale. Countries are at the center of working differently in this space, particularly for primary healthcare at the community level, which has gained a lot of visibility, and I'll share a little bit more on that later. And the leadership role of countries and communities is central to USAID's approach. And I'll frame this through our journey to self-reliance, communication focusing on optimal health systems that is coming soon, and our commitment that we made at the Primary Healthcare Conference in Astana, celebrating 4 decades of Alma Ata. And we are working with governments and partners to support the implementation of primary healthcare as well. So next slide, please. Slide 3, please. So the first is the broader context of how we are working differently. Oh, sorry, next slide, please. The previous slide, we skipped. No, the previous one. The previous slide. Can we get to slide number 3, please? We've gone back too far. Thank you so much. So sorry about that. The broader context of our commitment to work differently is really framed very well by Administrator Mark Green, who mentioned that each of USAID's programs should look forward to the day when foreign assistance is no longer necessary, and each country must lead its own development journey by financing and implementing solutions to its own development challenges. He stated this in August of 2017 as a part of our shift and focus on the journey to self-reliance and supporting country roles in this arena. And what it means is that as a country increases its commitment and capacity to plan, finance, and implement solutions to local development challenges, its level of self-reliance should also increase. Our metrics for self-reliance focus on commitment and capacity. And I've provided a link for you so you can take a look at the atlas and the country roadmaps, the broader roadmaps around the journey to self-reliance that you'll find interesting. We at USAID are also communicating what are the components of optimal health systems. And this is our US government policy priorities on health for all as they pertain to the journey to self-reliance. And this information will be coming soon in the form of a communication framework. And what we're really saying is that high quality healthcare systems should be accessible, accountable, affordable, and reliable. And integration of community health workers and primary healthcare at the community level is an accelerator in this entire context. Next slide, please. Next slide, please. Thank you. Finally, the third component, which is important because you've probably all taken part in the Global Conference on Primary Healthcare held at Astana. We have a renewed focus on the role and contributions of communities as resources in primary healthcare, both community-based services and empowered people and communities, in national commitments happening here at Astana, and USAID's commitment to primary healthcare was highlighted in the closing plenary. And we have ongoing participation in the primary healthcare implementers group. So we are a part of a broader collaborative that is not only trying to work with you closely to accelerate progress through primary healthcare to achieve universal health coverage and the goals in health, but also working with countries very closely around how primary healthcare at the community level is an accelerator in this context. Next slide, please. And here are just some voices from the Institutionalizing Community Health Conference that was held in 2017. I'll speak a little bit more about it, but you can take a look at this slide. The voices of government leaders who have helped us to define and shape priorities in thinking about how we institutionalize community health systems. Next slide, please. So one of the ways that we are working differently and where your role is absolutely critical, you are helping us to define the way forward, is in the form of these convening platforms, the Institutionalizing Community Health Conference that was held in 2017. 22 country delegations made commitments to advancing community health and supported these with action and learning plans, and approximately 400 champions of community health endorsed 10 critical principles for institutionalizing community health. And you can see that critical principle number 3 focuses on community health systems based recognition for frontline health workers, as well as formal health systems recognition. We are planning Institutionalizing Community Health Conference for 2019, where there will be an even stronger focus on you as health systems leaders to come together to define your progress and also cross-fertilize with innovations and other solutions that may be relevant across country context. So that's currently being planned, and we will be sharing an invitation for that in the near future. Next slide, please. Another way that we are working with you and working closely with health systems leaders in the community health space is on this community health roadmap. This is a collaborative effort across multiple institutions, including UNICEF, the Rockefeller Foundation, Bill and Melinda Gates Foundation, the World Bank Group, WHO is also involved. This entire effort focuses on elevating national government priorities for strong and sustainable health systems that promote, protect, and expand access to health at the community level. The national priorities that are elevated through this process by governments and their partners and health systems leaders at the country level help us to align and coordinate our investments in the space, and these investments that we are interested in improving, both in terms of efficiency and effectiveness, include domestic resources as well as donor investment. Next slide, please. So through this innovative process, we prioritized 15 countries where there was a potential to achieve impact in this space of primary healthcare at the community level. 6 countries have defined priorities that you can find at a website that I'll present to you in the next slide. 7 countries are currently developing the national priorities for primary healthcare at the community level. And these, once again, are shaping the way that we move forward. We help you to maintain momentum at the country level through rapid technical assistance. We align and reflect on the investments that are being made. We support your efforts to think through innovative financing, and community health workers as a critical component of primary healthcare at the community level, and their integration into the health systems, both formal health systems and community systems, is coming up as a critical theme. Next slide, please. The roadmap consists of multiple components. That we are developing this resource to support your efforts at the country level and to enable countries to share information across country contexts as well. The roadmap includes a background or a context, a vision for how we are trying to improve and elevate your efforts for primary healthcare at the community level, the national priorities that you've articulated, and ways that a whole host of partners and interesting stakeholders can join the process. And finally, it will also articulate commitments that we as institutions that are involved and other emerging investors in the space are interested in making. So there are critical policy questions and challenges that countries must ask to rationalize, sustain, and scale up community health policies and programs. And these include harmonization, classification, and nomenclature, lack of inconsistent system support, both from the formal system as well as from the community systems and communities, coordinated planning at the national and subnational level, motivation of volunteers, financing. And I'll close with sort of a country example. What did Niger's ministry and its key partners prioritize to accelerate the development of a national community health strategic plan for primary healthcare? They prioritized developing an investment case, and doing a financing gap analysis and a detailed partner mapping in Niger. As a part of this process, establishing a multi-sectoral committee for community health and primary healthcare, extending supervision, procurement, and health information systems to the community level, and improving gender dynamics. So our question then becomes, how do we take these priorities, country priorities, and further work with you to ensure that these country priorities are then further translated and integrated into country-level processes, both in the context of broader primary healthcare, as well as other types of investments that may include the Global Financing Facility investment cases or the human capital investment dialogue that is ramping up, particularly in Africa. So as a group of committed funders of community health, we are listening to you closely as you prioritize and chart your longer-term vision for community health in your countries. And we are learning about how to coordinate and rationalize our investment and sequence it over time to achieve impact for the systems lens. And we look forward to hearing your voices as a part of the course and other global and regional platforms that are promoting cross-country dialogue and community health, as well as digital health that you may be familiar with. Thank you very much.
Thank you very much, Nazo. That was an excellent presentation. I know, Nazo, you may not be hearing me, but Sidi, could you help us with passing on my messages to Nazo? Sidi?
Awesome, sounds good. Sounds great.
Okay. So there are a couple of questions coming through from the audience. And I would like to pose those questions to Nazo for her response. There are questions about the provision of a copy of the 10 principles of institutionalizing community health. And maybe if Nazo could speak to these 10 principles just a little bit, if she could make some comments about the 10 principles for institutionalizing community health.
We have a question about where you can find the 10 critical principles for institutionalizing community health.
That's correct.
We set up a resource site for the Institutionalizing Community Health Conference. And in my slide, this is an active link. And if you click on the 10 critical principles as well in the slide, you will be able to access both the long and the short version of the critical principles.
Great. So, Nazo, do you have visibility on in the chat room? There's another question for you.
I believe I'm being asked to, I apologize for not being able to access the questions directly, but I'm being asked to speak a little bit more about 10 critical principles. A little bit of history here. When we developed, or when we put on or organized the Institutionalizing Community Health Conference in Johannesburg in 2017, this was a critical opportunity to speak with countries and to ensure that the paradigm shift that was being driven by multiple streams of work, not the least of which is systematic reviews of evidence and a growing body of evidence around positioning community health in a much stronger policy and systems contexts. We wanted to understand and ensure that we were moving in the right direction, and where did countries want to go to set the agenda in this space. And the 10 critical principles for institutionalizing community health, 2 of which I provided in the slide for you, was a way for 400 champions for community health who had gathered in Johannesburg at this conference to say, we very much are interested in driving a paradigm shift in community health that focuses on critical areas of institutionalization, and that's what the 10 critical principles are. These critical principles were worded and endorsed by the champions who were participating, primarily of whom were community health leaders and health systems leaders from 44 countries. And they were organized in 22 country delegations that also made commitments to institutionalizing community health and developed 18-month action and learning plans that we have been following. We have set up, at the request of these country delegations, we have set up a community health community of practice that has continued and is a space for providing input collectively across countries to documents such as the Astana Declaration to assess what should be the components, how you as countries are defining the components of primary healthcare at the community level, which ones are the most critical, where the linkages remain weak. And we are developing and planning an institutionalizing community health conference in 2019. And UNICEF is leading this effort, but with an even stronger country focus. Over.
Thank you very much, Nazo. In the interest of time, I know there are still a couple of questions, but in the interest of time, I'm going to ask for, if Jim is on the call now, for Jim to make his presentation, and then we can come back to further questions for Nazo.
Magnus, this is Catherine Kane from the Health Workforce Department. Unfortunately, Jim was called into an urgent meeting with our member states this afternoon. We're preparing for the World Health Assembly quite shortly, and he's not been able to break away from that meeting, but offers his sincere regrets. In his stead, I can either offer to go after you and still cross my fingers, or I'm happy to present on the community health worker role in UHC.
Thank you, Catherine, for letting us know. I will suggest you present on his behalf if you are available to do that now.
Super. And again, I do offer Jim's regrets that he wasn't able to join. I think he was very enthusiastic about talking about this overall.
I know, and we appreciate, fully understand the situation.
Super. So we'll just go to the first slide, and I know I'm preaching to the choir, as they say in my country. We'll go to the next slide. As you all know, WHO, embedded in its constitution, is the idea of health as a fundamental human right for everyone. And you'll notice this this aligns nicely with what Nazo was saying with regard to the USAID priorities, is that we look at governments as being responsible to ensure the provision of adequate health and social measures. That was followed up. We start seeing the community health workers more strongly recognized as we move into the Declaration of Alma-Ata. Primary healthcare relying on suitably trained health workers. Community health workers are key parts of this team. Within the Sustainable Development Goals, we've got UN member states that say we're going to try to achieve UHC by 2030. They put those in the SDGs. There are specific goals related to the provision of health services, of primary health care, of strengthening health workforces. And then we get to the Declaration of Astana, which of course is a big favorite for me, because this is where we recommit, 4 decades later, we recommit to primary health care as a cornerstone of UHC. And we launched the first ever community health worker guideline. We looked at evidence, we looked at expertise, and we brought together a review of all of that evidence to give recommendations on how to structure the policy and system support for community health workers. The world is increasingly understanding community health workers as a key to providing primary health care. And as I said, Jim has been called into a briefing with our member states because we have something that's extremely exciting for this team, which is that the World Health Assembly, happening at the end of this month, is going to consider a resolution that was already adopted by the WHO on community health workers delivering primary health care, opportunities and challenges. This is health, and we want to see how we can use these programs effectively as part of our primary health care agenda. Next slide. So as you all know, there are a lot of challenges that face the health workforce and the community health workers more specifically in our aims for universal health coverage. We have a number of tools within WHO that start to answer some of those questions, like lack of health workers. We've got the Global Strategy on Human Resources for Health from 2016 that recommends a diverse, sustainable skills mix. We don't look at community health workers as the be-all, end-all solution, as a cheap solution to hire trained health professionals. We look at them as part of the team who can address some of the gaps and help the health systems extend further. And as we've got these unevenly distributed health workers in facilities, a lot of people are cut off from care. We've got community health workers, and as we select and train the right people, they come from, work in, have the trust in, speak the language of those communities in which they're working. And with the health system links that are encouraged through the guideline and through our entire health workforce approach, these community health workers are supported within the health system, not as separate projects, not as community-only projects, but connected integrally with those health systems for referral, for supplies, for supervision, for training, and to ensure that they're actually contributing to providing primary healthcare services. With these vulnerable communities, community health worker services can be both an effective and cost-effective approach to reaching, as Raj framed it so beautifully, that last mile. And they're often members of vulnerable groups. If you look at HIV community, a number of people from the HIV community have been recruited as community health workers and have a unique role in accessing other members of the community and helping the health system gain trust and gain compliance. We're also looking at, in a number of countries, gaps in health worker training, gaps in support, gaps in supervision, and all of those make for weak community health worker programs that don't actually extend the primary healthcare goals. So as we engage human resources for health strategy and planning, and include community health worker programs, we move forward to connecting communities with their health system and ensuring that those communities not only are receiving services, but are well expressing their need for services. Next. We've got the community health worker guideline, and many of you will already be familiar with it. We also pulled in threads from our overall human resources for health workforce approach, which is gender sensitive, evidence-based. It's looking at the system and policy level considerations. While many countries will go more in depth, what we want to do is ensure that their health policy reflects the community health workers as part of their team, as part of their resourcing. And we suggest some tools for national uptake of the guideline, which we anticipate will get even greater support as that resolution is considered at the World Health Assembly. Next slide. What makes this successful? Community health workers are different in every country. There are similarities between contexts, and we certainly are encouraging and promoting sharing best practices. We also, in line with the Working for Health agenda within WHO, are looking at the decent work agenda for community health workers. So they should have decent work, remunerated, free of discrimination, good leadership that is gender and equity represented, and should be included in gender transformative policies. I've talked about embedding in the health system, can't say how important that is to actually being able to measure and ensure that primary health care is delivering what it needs to for countries. And further, one of the most important elements that we look at is that community health worker programs don't only contribute to SDG 3, but they also contribute to employment and to education and to economic opportunity by creating employment opportunities for vulnerable communities, youth, women. And so we look at this always, and we look at these supervision elements as ensuring that we're delivering quality care and patient safety. So these programs that are embedded in the health system, part of the policy, supervised by higher level health professionals, we all want to deliver quality services, and the guideline will help to deliver those services. You can see in the following slide that there are a number of areas, and these are primary healthcare interventions, the promotive, preventive services. We have evidence that has been reviewed by experts that community health workers are an effective and cost-effective approach to dealing with a number of these issues that are challenges in many countries in trying to achieve their UHC and SDG goals. We also look at the future of the health workforce. We hope that as we progress towards universal health coverage and as we start to see progress against the Sustainable Development Goals, that there is a career path for community health workers, that as the health needs of a nation grow and change, that the community health worker programs are providing the right career paths and the right training so that these workers remain viable parts of their economies, of their communities, and of the labor market. Dr. Tedros has said so many wonderful things, recognizing that about 80% of all of health investments are actually in the health workforce within the health economy. We must ensure that the basis, the backbone for any healthy health system is that you have appropriately trained, resource-supported, gender-appropriate health workers. You can see that within our Working for Health agenda, there are a number of threads that talk not only about primary health care, universal health access, but talk about the fundamental needs for appropriate health workforce approaches. And we are working with partners. Not only do we work with government agencies who are partners to other national governments, we also work with important members like our community health worker knowledge hub, of whom I believe that there are some very strong members here, to ensure that we have a collaborative approach, a partnered approach. Nobody's going to achieve this on their own. So just as Nazo was referring to getting groups of advocates together, getting a team together, collaboration. At the WHO level, we're also working with the ILO and the OECD to ensure that the labor elements of the health workforce agenda are well supported. You'll see how this is contributing towards the Sustainable Development Goals and are part of the 5-year action plan to support governments and stakeholders. So a little bit, and I think one of the elements that's important as we're talking to national governments about community health workers and talking about why it's a good investment in their primary health care is that there are growing needs. There's an 18 million health worker shortfall that we anticipate by the year 2030. Now, I know a lot of you are thinking, well, there's a shortfall, but there are so many people out there who need jobs and there are such growing health needs. How do we make this equation work? And I think that community health workers are very much part of the equation on how we invest appropriately in countries and invest in health workforces that can actually deliver. As I mentioned, CHW programs contribute to job creation and economic growth. Within the WHO investment case, we talk about the value of UHC investments, generating a 40% return over a 5-year period. This is a good investment. And when we share this multi-sectoral approach that you've already discussed with Nazo, we develop the partnerships with national governments, in support of national governments, where we bring in all of the resources, including, very importantly, civil society community organizations. Many of you probably followed the high-level meeting preparation in New York last week, where we heard from civil society organizations about what their goals are with regard to participation in and value add for the UHC agenda. Finally, I just have I have a number of references to which you can take a look after this presentation, and we'll skip this slide because it's not actually that interesting. What I want you to see is something that was the preface for the Community Health Worker Guideline. This is the head of health in the world saying, we must harness the potential of community health workers by dramatically improving their working and living conditions, and together we make progress towards the UHC and SDG health targets.
Thank you, Catherine. That was excellent. I think Jim has been well represented here in his absence, and I truly appreciate your contribution. Catherine, can you hear me?
Absolutely. I'm never gonna substitute for Jim, but I'm glad that I could step in at the last minute.
Okay, there are a couple of follow-up questions from the chat box. The first one is, will this community health worker training include midwives to combat FGM and the local disempowerment practices for women?
Well, it's a great question. So there are several parts of that. One of them is that as the Health Workforce Department, as the champions of human resources for health globally, we actually work very closely with nurses and midwives. And our perspective is that when community health workers are integrated in the health system, they need to be working well with nurses and midwives, both for referral and for supervision. So with regard to the specific FGM agenda, it depends on the country context. We certainly see that there are some very appropriate roles. Several years ago, I was on the Ebola response in Sierra Leone, and we together were working with the SOEs to find appropriate solutions so that there weren't dangerous situations created by the FGM practice during a time when there was such high disease transmission. Within country context, appropriate to national goals and health strategies, certainly there could be roles for community health workers, and certainly we believe that they have an important integration with nurses and midwives in a number of different areas.
Thank you, Catherine. A couple of other comments on the chat box which do not require your response, but just to flag, as observations. The first one is that the ICT has a potential for capacity building for community health workers in terms of continuing medical education and data management. And that is so true. The second comment is that the standardization of names used for frontline health workers is another area that needs to be discussed. Like doctors, doctors everywhere. There is only one nomenclature for them. Whereas with frontline health workers, we have not yet standardized a nomenclature for that. So these are very good observations. I will not invite any comments. I would like to proceed with the next presentation in the interest of time. And any time that we have left, we could use that for Q&A at the end of the session. Sidi, could you kindly put up my presentation, please?
Yes, awesome. We should be seeing your presentation.
Great. So last year, the Astana Declaration emphasized the primary role of governments at all levels in promoting and protecting the rights of everyone to enjoy or the enjoyment of the highest attainable standards of health. Already you've heard from Nazo's presentation and the reference she has made to the role of governments and communities. You've also heard from Catherine's presentation on behalf of Jim that strong community health systems are and will continue to be key to achieving this vision of providing healthcare for all. We know that when governments are in the lead and supported by stakeholders like ourselves, as they design, scale, and sustain their community health work programs, this leadership can successfully scale national programs. Examples of such countries who have achieved this are Ethiopia, Bangladesh, and Liberia, who have all illustrated that this is possible when you have government leadership with support and alignment of the international community. For example, let's look at the Ethiopia case. The success in creating the health extension program was due to the political will and political action, starting from the Prime Minister himself and the strong support that was followed by the general international community that supported that program and aligned behind the Ministry of Health. Dr. Tedros, then Ethiopia's Minister of Health, also saw the value in building strong community-level health systems and mobilized partners around his vision and got donors and other implementing partners to support that vision. This high-level support ensured accountability and inspired confidence, both internally within Ethiopia, but also externally in terms of the international community looking in to see what Ethiopia was doing. We also know that when donors and partners are not coordinated, and definitely with governments not being in the lead, this contributes to fragmentation and small-scale projects which fail to be sustained and end up just as silos, and once the funding comes to an end, will fail. As long as NGOs operate in silos and are focused on the work that they are in control of, they can never be unified or successful. And government-led approach for health systems delivery is the only game in town. So how can partners better provide technical assistance? And what frameworks can both governments and partners employ to maximize collaborative results? Next slide, please. In the Community Health Academy's new course on strengthening community health worker programs, we talk about 5 key components to successfully build coalitions to support government-led CHW programs. We talk about partnership, which has already been referenced, and the need to work collaboratively with governments, donors, and implementing partners, as well as the communities that we seek to support. We should take a demand-driven approach, which means that we are assessing the needs of the countries that we are supporting and working with, and reflecting those demands into programmatic development and funding streams to make sure that we are country focused, and that it is the strategic agenda of those countries and the needs of those countries that we are addressing. Taking a management and business skills capacity building approach, making sure that we are building the capacity of government and implementing partners to deliver on those programs that have been designed collaboratively with government. Introducing advocacy expertise, which ensures that collectively we are advocating on behalf of government, on behalf of the populations that we serve. And where governments are not aligned with the strategic needs of the country, we can use our advocacy role to ensure that those realignments are made. And of course, supporting then the leadership role of government itself. Next slide, please. So how is the Community Health Academy contributing to these government-led partnerships and CHW programs? The Community Health Academy, which was launched in 2017 at the third wish that was made by Last Mile Health CEO, Dr. Raj Punjabi, we are leveraging the power of digital training tools and partnering with ministries of health to strengthen the clinical skills of community health workers and their supervisors and those health system leaders that support them in an effort to achieve a health system strengthening approach and a community system strengthening approach. It is also creating global partnerships to achieve this goal and empowering community health workers to be able to deliver healthcare, improved healthcare at the last mile. Next slide, please. So we are all in this effort together, trying, first of all, to create a global classroom to support health systems leaders. The Community Health Academy will enroll and help to upskill over 15,000 community health workers by 2021. We are currently working very closely with Harvard University through the Harvard X team and the edX platform in co-producing the Community Health Academy's first course on strengthening community health workers programs to deliver primary health care. And we are doing this through a collaborative partnership and working with not just national governments and ministries of health, but also the international community through a global faculty network. Next slide, please. This global faculty network is drawn from international partners and experts in the field, but equally, we are drawing in partners from implementing organizations who are also experts in their own field and contributing to the design and implementation of national scale community health work programs in a number of countries. And as you can see from this montage of photographs, we have representation from the World Bank, from the International Institute of Primary Healthcare in Ethiopia, from WHO, and from UNICEF, as well as other implementing partners like CHAI and Partners in Health. Next slide, please. We are in the process of setting up 2 regional hubs, one in Liberia, at the University of Liberia, to support the West and Central Africa region. And similarly, we are in the process of setting up a regional hub in East Africa to cover the East and Southern Africa region to ensure that we are able to recruit a regional faculty network of experts in those regions that could bring in the regional contextual perspective and expertise in terms of our design and development of the health systems leaders training programs, as well as the community health worker programs. Next slide, please. And subsequently, we intend over the next couple of years to also establish hubs in Asia, Central and South America, as well as North America. And these regional faculty networks will also help to facilitate and support regional and global communities of practice that we intend to either set up or augmenting and supporting existing communities of practice. Next slide, please. So finally, we would like to invite you to join the Community Health Academy in accelerating this vision, this global vision that we have of supporting the health workforce capacity building agenda to address the quality crisis that currently exists in the delivery of healthcare to all, including those very remote communities. If we are to do so, we need to be able to build not only the capacity of community health workers and frontline health workers, but also health systems leaders. And we've just recently opened for registration our first online training program, which is for strengthening of community health worker programs to deliver primary healthcare programs at the front line, and to ensure that that capacity is built right across the board. So we would like to invite you all to visit the website, either the Last Mile Health website or the Harvard University website, and looking at the possibility of registering for our first course, which is free to access, and one that you can take at your own time, in your own pace, with a fee of $79 to get a Harvard certificate on completion of the course. So thank you all for attending this webinar. I would now like to open it for any further questions that may be still outstanding. I see Jim is with us again. So Jim, welcome. We understand you are engaged with other high-level meetings, so we fully understand and appreciate your time. Catherine has done a terrific job in presenting on your behalf, but I'll just give you a couple of minutes to say a few words. Jim?
Thank you very much, Magnus and Nazo and colleagues, and appreciation to Catherine, who stood in for me. My apologies. We were caught in preparations for the World Health Assembly, which is coming up in a couple of weeks. Exciting times. One of the conversations we had was with the co-sponsors of the resolution on the role of community health workers in primary healthcare. And that's going to be very much aligned with the initiative that we're talking about here today. How to really turn evidence into practice. How to translate the guideline that we have on efficiency and the effectiveness of the role of community health workers, community health providers into practice at the country level. How to work with our partners to accelerate this knowledge uptake. And so credit to all concerned in developing the Community Health Worker Academy that will help us launch this evidence and translate it into practice where it is needed most. From an assembly perspective, this is a milestone that we recognize, but it is the beginning of the work that we need to go forward. And thank you to all the collaborating partners in the Community Health Worker Hub, to all those that were involved in consolidating the evidence for the guideline, those that supported the launch in Astana. And we do wish everyone well. And I look forward to meeting and working with the alumni, because once we have more practitioners, more leaders that are able to articulate the value, the objectives, and the return on investment from investing in the education and employment of this occupational group, with the supportive supervision, with their rights and their dignity respected, with terms of contract, with appropriate remuneration as necessary and as determined at the national level, we are taking a big step forward into strengthening primary health care and moving forward and accelerating progress on universal health coverage. So thank you very much, Magnus, and to all engaged and your participants from around the world.
Thank you, Jim, for your efforts in leading all of this work at the WHO level and for your partnership and collaboration as well. Before we leave, I would just like to invite our CEO, Raj Panjabi, if he has any closing remarks before we take the final question. Raj, are you available? I'm not sure Raj is connected to the Google Drive. Okay, so let me just take one last question, and I'll pose this question to both Jim and Nazo, as this is a very important question that has been asked by a member of the audience. And they started by saying that they're not trying to be provocative, but they wanted to ask the question, why do community health worker programs necessarily have to be government-led? Why not private sector-led? With few exceptions, government-led service delivery programs are notoriously poorly run and unresponsive to user needs. So the question is, why not private sector-led community health work programs instead of government-led community health worker programs, which have been known notoriously, according to the participants here, have been notoriously known to be poorly run and unresponsive to user needs. Jim, I'll give you an opportunity to go first.
I was going to say ladies first, but indeed, and it's not meant to be provocative, but I think it's a very pertinent question that we need to recognize. In many countries, we do recognize that faith-based organizations, non-governmental organizations, those philanthropic foundations that have a not-for-profit mandate are also actively engaged in the provision of services to the community. We also see the role of private sector engagement in education more broadly. And if we look at the scale of the acceleration that's needed on primary healthcare teams, indeed, there could be significant roles for leveraging the business acumen, the opportunity to have private sector engage. At the same time, the evidence clearly states, and as WHO's role in convening and engaging and looking at the evidence, the ambition of universal health coverage, the ambition of health for all, of equitable access, is often most successful when there is public stewardship, with public stewardship, with public funding and financing to ensure that people can access quality care. And so in each country, there needs to be the appropriate consideration of how to work with partners, for-profit, not-for-profit, different sectors, of how to accelerate our education in the first instance and the role of service provision. But it needs a very, very strong public stewardship and governance function to meet quality standards, to ensure that people who are in these roles are accredited and supported and supervised, to ensure those quality standards and to protect the public from that ethical perspective. So each and every country has to look at how it identifies the opportunities. Thank you, Magnus.
Thank you, Jim. Nazo, could I ask you the same question?
Are you able to hear? I hope you can hear me. I would like to second what Jim has just said about the importance of national government stewardship for large-scale community health worker programs and large-scale systems that are functioning optimally. With that, I will say that the work that we are doing with countries to elevate national priorities, and as Jim said, each country is at a different stage, whether it's defining and articulating new priorities and strategies or addressing and refining the challenges posed by currently fragmented systems that are in place. We are interested in strengthening the collaboration between governments, the private sector, including civil society, both for-profit and non-profit, and linking them much more closely with communities. We feel that nationally defined priorities and coherence to implement the newly defined and or refined community health policies and strategies as a part of primary healthcare is essential. We need to focus on inclusive partnerships and processes at the country level that bring a variety of stakeholders together. So it's not an either or. Depending on the country context, all kinds of collaborative efforts can be steered and led by the government, with a role for each type of stakeholder within that. And countries such as Bangladesh that are articulating or introducing sort of a new community health worker strategies are looking at both public and private providers to move forward together, so that you can achieve impact at scale. Over.
Thank you, Nazo. Thank you, Nazo and Jim, for your leadership in this area. I will now hand you over to Raj, our CEO, who was the visionary that set up the Community Health Academy. Raj?
Thank you, Magnus. Can you hear me, Magnus?
Yes, I can.
Well, I first of all just want to thank Nazo and Jim for joining the efforts today, and Magnus, to you for facilitating. You know, I'll just say this. I think we all share the belief that the key to universal health coverage and to primary healthcare is to involve and to grow the healthcare team, is to actually engage everyday citizens in the work of being community health workers, in the work of working with nurses and doctors to extend reach to every last child and family on earth. And I think, Jim, the work that the WHO is doing this month with the World Health Assembly, Nazo, the work of the Community Health Roadmap, to see countries that are making real commitments, real investments, arguing, as you said, for the rights of these workers to be paid and contracted, arguing for better supervision, arguing for stronger quality of care at the last mile, and is so critical for this. It's incredibly inspiring. We hope that the skills, the perspectives, and the experiences that you will learn from Nazo, that you will learn from Jim and his colleagues at WHO on next week's launch of the Community Health Academy course will be useful to all of you who are trying to do this work and build stronger systems in your own country. You'll hear from colleagues in Bangladesh as well, Ethiopia, Liberia, and from many others around the world. And I hope you'll keep the feedback coming to all of us on how to strengthen these courses and make them useful to you. But thank you, everyone. Look forward to keeping the movement alive.
Thank you very much, Raj. And finally, I would just like to sincerely apologize for our late start, and now we've run over, and also to apologize that I know there are other participants online that wanted to contribute to these discussions or to ask questions. Unfortunately, we're out of time, but I want to assure you that we still have a series of webinars that we are hoping to host pretty soon. I think there are 2 already lined up for the coming month or so. We hope that you will continue to support this movement by participating in these webinars. So thank you all to all those who supported the planning, the organization, and the running of these webinars. I'm not going to be able to name all of you, but most importantly, Tech Change for hosting us, and also all of you as participants that made time to join this first webinar. Thank you so much. We look forward to working with you, and we look forward to seeing you on our first health systems leadership training program on the edX platform. Thank you and goodbye.